Common pediatric nutrition problems and considerations. The following slides are going to be a couple different things that we run into in the pediatric world that I do want you to be familiar with, but I didn't, again, want to take as much time in class doing these, and again, wanted to look a little bit more about our ability to learn to apply this kind of information on an everyday basis. So the first concern that we have is childhood hunger. Food insecurity is a significant problem in this country. Approximately 10% of US children find themselves in a situation that we would describe as food insecure. Food insecurity, remember, is the inability to acquire or consume an adequate quality of food, as opposed to those of us who are blessed enough to be able to have access at all times to the nourishment that we need and the healthy lifestyle we need. Poverty is one of the greatest causes of food insecurity, and I know that in many of us who are doing community home in some of the areas where it is riddled with poverty, we do see a lot of food insecurity in our patients that we work with. Greater than 1 in 5 children is poor in this country, and some of those poor children don't even qualify for assistance for various different reasons. The other cause that could come into play is special needs nutrition. You're going to learn in this course that there are certain disease processes that require children to have certain types of formulas and foods, and the cost of those can be rather prohibitive to a family who's already struggling financially. Again, probably a repeat for a lot of you, but food insecurity or insufficient nutrition does cause various concerns and conditions in the body, such as anemia, poor growth and development, especially in pediatrics, something that we're tracking and following at every well-child visit. Additionally, as we all do know, as we age through a period of food insecurity and inadequate intake, our risk for cardiovascular disease and diabetes rise significantly. This table is from your book, and it is just a brief look at some of the questionnaires that we can use, or some of the questions that we can use to screen for food insecurity. You've probably seen this before, but do take a look at it so that you are familiar when working with young families. The second concern, we go from one extreme to the other, food insecurity and inadequate intake, to overweight and obese young children. Currently, right now in the United States, we have a historic percentage of young children who are in the obese range. And remember, we say anything greater than 95%, the 95th percentile on those growth charts is considered obese. Currently, right now, we're having a significant increase in those, as we have indicated, and do need to track and follow this very closely. What we're finding is almost epidemic levels of type 2 diabetes, stroke, hypertension, sleep issues, depression, anxiety, etc., and on and on. So a body mass index of greater than 95%, the 95th percentile is considered obese, and that is approximately 17% of children in the United States today. On the 85th percentile, we begin to be concerned that you are overweight. You are not considered obese, but you are overweight and heading in that direction. And that also includes about 17% of the children in this country. So when you look at that, 34% of the youth in this country either fall in the concerning overweight range or in the obese range. And that is epidemic and something that we do need to pay close attention to. There are specific risk groups: non-Hispanic Blacks, Mexican Americans, and Native Americans. When we look at that epidemiologically, we do see that those particular groups have a higher risk. Some of the influencing factors, as we've begun to study obesity and overweight tendencies in the youth population, what we did find is not a surprise. We have a lot of young children with decreased exercise, a much more sedentary lifestyle, spending more time at home, doing video games, on the internet, on social media, on the TV or Netflix, etc. We have also simultaneous to that, a lot of kids who are getting an increased percentage of fat and sugary foods. They're quick and fast and easy, and in many cases they are cheaper than the healthier foods. And that combined with that sedentary lifestyle and lack of physical activity has really had an impact on those numbers. So when we work with children who are deemed overweight or obese, obviously we're going to assess them as we would assess any others that had a concern about weight of any type or BMI of any type. We will diagnose them via their BMIs, height and weight on those growth charts. And we need to work together as a team and have realistic goal setting. Remember, we can't go from 0 to 60. So we can't say you will never have sugary foods again or high-fat foods again or fast food again. We have to think about how do we put those into much more manageable small goals that allow young children and youth to feel success in taking control over their weight, their exercise levels, and becoming less sedentary and more healthy. And to deem success with that is to go ahead and watch them on that growth curve, follow them, watch their health changes, watch their decision-making changes, and overall physical activity and dietary intake change and improve. Food safety in this country, yes, is still, while we tend to associate that more with other underdeveloped countries, we do still have food safety concerns. Certainly, we haven't been immune to some of the concerns of pulling foods off the shelves because of contaminations that have occurred. So there are a lot of foodborne illnesses that range from mild cases of diarrhea or GI upset all the way to the severe, where we have patients that are hospitalized as a result of these conditions. It is important for us to teach our patients about how to prepare their food, cook it properly, cook it completely, wash fresh fruits and vegetables, and don't count on the items that have been packaged to have been thoroughly cleaned and rinsed. And so that sometimes does become a part of some of the education that we give our patients. Mercury contamination, I do just briefly mention because we do tend to have the risk population for this be in our infants and very young children as well as pregnant women because fetuses are very at risk of mercury contamination. The best way to handle this is to remove those types of things and eliminate those high-risk fish so that we don't have contaminated fish being eaten by individuals who are at great risk for that contamination. And the Food and Drug Administration has recommended the intake patterns for that. So we have a couple deficiencies in pediatrics, and I wanted to just look at the most common that we see as we work with children. Our first would be iron deficiency, and most commonly iron deficiency anemia. By about 4 to 6 months, infants' iron stores begin to decrease naturally. And so we know we need to provide them with high iron sources. And the first foods that we administer infants are iron fortified rice cereal. Rice cereal is the easiest to digest and is also iron fortified so that we can begin to restore those iron deficiencies. If we don't take them in, the infant can develop anemia. We do not give cow's milk to infants until they are over a year of age because it can cause anemia, believe it or not. Cow's milk can be very irritating to the infant gut and cause slight irritations and small losses of blood, which ultimately can lead to an anemic state. So there is no cow's milk until the child is over 1 year of age. Adolescent females are at risk also due to menses, growth spurts, their periods cause them to have blood loss and thus iron deficiency. Good iron sources, eggs, meats, often things we think of. Iron fortified cereals are becoming very popular now as well, and it's definitely something we can recommend to our patients. Calcium deficiency, as we know, calcium is very important for bone development. We notice a lot of this in the adolescent population. So 40% of our bone development is taking place, and at 18 years of age and 20 years of age, about 90% of our bone mass is developed. So until that point, we really need to have high doses of that calcium intake. Not enough intake will result in osteoporosis much later in life. So while we may not note major things early on, we can develop long-term complications. Obviously, milk Dairy products, eggs, nuts, etc. can include calcium sources. Female athletes that go through excessive dieting to stay fit, in their definition, fit and capable of competing, often fall into a triad called the female athlete triad that we do see in our adolescent population. These young ladies are excessively thin, do excessive exercise, and have lost their periods. You may know people who have this particular condition, and as you can imagine, they have calcium deficiency, they are anemic, as well as some of the other complications that go along with excessive exercise and being excessively thin or an inadequate intake. Vitamin D deficiency, actually, while we see it in pediatrics, it's something that many Americans suffer from at all ages. Infants that are breastfed have a risk of vitamin D deficiency, and I mentioned that in one of the previous voiceovers. Us generally, as adults and young children, have less sunlight exposure where we may be able to absorb our vitamin D. And we do need vitamin D to mineralize our bones and to help us absorb that calcium that we may be taking in. So we do often have to supplement breastfed babies and potentially young children with vitamin D 400 IUs or international units per day to ensure that we are absorbing calcium and mineralizing our bone. Folic acid deficiency. Folic acid is taken in higher doses in the pregnant mother because it is essential for neural tube development. And without it, we can see neural tube defects, things like cleft lip and palate, spina bifida types of injuries as a result of insufficient development of that neural tube. Adolescents and childbearing women are at greatest risk for folic acid deficiencies. Finally, that protein and energy malnutrition, often seen in third world countries. This picture very much always smacks to me of protein deficiency. This young child has what we term kwashiorkor, which is associated with that very protuberant belly and is a significant sign of protein deficiency. Calorie deficiency may look instead very emaciated and be very lethargic and lack energy. But that protein deficiency is a pretty classic sign, that large belly. Young athletes is another group that we do need to pay attention to, especially as they enter that adolescent age bracket. We need to monitor the intakes they may be having in terms of calcium, iron, as well as hydration. But additionally, we do want to talk to them about the use of supplements in terms of steroids and creatine, which we do see more and more of in that adolescent population. They need to know the dangers of that, but also need to know about proper hydration to help with recovery, sports drinks versus water. We have so much Gatorade out there and Powerade, but the reality is that water is the best source of rehydration, and we need to educate them so that they can avoid some of the sugars found in those sports drinks. Vegetarianism is something we are seeing more of, and we are seeing more and more alternative diets. As a general rule of thumb, let's just be clear that we need to assess the intake of anyone on an alternative diet and ensure that it is balanced. Just because you're on a vegetarian diet or an ovo-vegetarian diet or a vegan diet doesn't mean that it's not a healthy, balanced diet. We need to assess it to be sure that it is, but many people function very well on these. Be clear, ovo-vegetarian eat eggs and dairy. Lacto-vegetarians eat dairy only, no eggs. And vegan is very strict, no animal products of any kind. We need to make sure, as I said, that we are looking at all of the intake. It would not be uncommon for vegetarians to need some vitamin B complex supplementation as well as vitamin D. Final concern or things that we need to look at in the pediatric world is enteral therapy. In the labs this week, we did do feeding tubes, and many kids do need supplementation or complete feeds via enteral feedings due to a medical condition that they may have underlying. They can be in the form of a nasogastric tube or a gastrostomy tube, as we talked about. And really, we just need to monitor dietary intake on these and make sure that we are plotting them as we would any other child eating to make sure that they are staying on target and growing and developing as we would want.